A hospital bill for $1,250 represents a charge. This is a sticker price shaped by insurance contracts and market leverage, and it rarely reflects the actual value of the resources consumed by the patient. Extracting an accurate unit cost from a modern healthcare facility is difficult. Hospitals are multi-product environments. A single nurse splits their shift between a surgical bay and an outpatient clinic. A patient's care requires a fraction of an MRI machine slice stand, a portion of the building's electricity, and a share of administrative labor. In health economics, the unit cost is the mathematical valuation of every specific resource, down to the minute of physician time and the milliliter of medicine consumed by one clinical episode. Accurately mapping this resource consumption requires establishing a rigid costing methodology before any data is collected. Without that predefined methodology, attempting to compare the efficiency of a hospital in London to one in New York yields a mathematically invalid result. The first step in any methodology is defining the analytical lens. The model must declare which specific type of cost is being measured. Financial costs are historical accounting outlays. This is the literal money spent by a facility, visible on their ledgers and procurement invoices. Economic costs measure the true opportunity cost to society. This captures resources that bypass the accounting department, such as donated medical equipment, volunteer labor, or the unpaid time of family caregivers. This chart shows how these cost types intersect with the perspective of the analysis. The horizontal axis separates financial outlays from economic costs, while the vertical axis divides the perspective between the healthcare provider and society. A provider perspective restricts the model to internal financial outlays incurred directly by the facility. If the hospital did not pay for it, the model ignores it. Expanding to a societal perspective forces the model to measure external economic factors, including patient out-of-pocket expenses for travel and the impact of lost workforce productivity. The chosen analytical perspective acts as the gatekeeper, dictating exactly which variables are permitted to enter the final calculation. Every input resource in a clinical episode must be classified before any mathematical valuation begins. This chart shows the input distribution of a community health center compared to a district hospital. Notice how the proportions of resource consumption shift depending on the scale of the facility. Resources like drugs and consumables are variable costs, meaning they scale with patient volume. The building space is a fixed cost, remaining constant whether the hospital treats 10 patients or 10,000. Clinical staff are often step-fixed costs. A single nurse can handle a baseline number of patients, but crossing a specific capacity threshold requires hiring an entirely new person, causing the cost to step up. Costs are also classified by their traceability. Direct costs are resources exclusively attributable to one patient, like the specific gauze used in a surgery. Indirect costs, or overhead, are shared resources. Apportioning the electricity bill or IT infrastructure to a single appendectomy requires a precise allocation formula. Finally, we distinguish recurrent costs, like syringes, from capital costs, which are assets with a lifespan greater than 1 year, like an MRI machine. Capital costs require depreciation modeling to distribute their value across their entire useful lifespan in the cost estimate. Misclassifying an input, such as treating a fixed capital asset as a recurrent variable cost, invalidates the final cost estimate. Once the components are classified, the data enters the valuation engine to calculate the final unit cost. The first engine is the top-down, or gross costing approach. It begins with the facility's total annual budget and slices downward, dividing total expenditures by the volume of services provided. It utilizes apportionment statistics, like total annual bed days, to step total expenditures down to the department level and then to an average cost per patient. The primary advantage here is feasibility. It pulls from existing administrative databases and hospital ledgers, which are usually readily available. Top-down models frequently rely on cost-to-charge ratios, applying a facility-wide discount formula to a patient's billed charges to estimate their actual cost. The critical blind spot of the top-down method is its assumption of patient homogeneity. By averaging expenditures, it obscures the resource variations caused by severe individual complications. Top-down valuation is an efficient tool for budget planning, but it remains a blunt instrument when evaluating individualized patient pathways. The opposing engine is bottom-up, or microcosting. Instead of starting with the budget, it starts with the patient. This calculation identifies every single resource unit consumed by a specific patient and multiplies it by the exact monetary value of each input to build the total cost upward. Microcosting provides high precision, capturing resource-heavy cases and unique patient complications that average out in a top-down model. The drawback is that the process is labor-intensive. It requires tracking primary data for every resource used, which is expensive and often requires researchers to manually log physician time. Because this data collection is so intensive, microcosting relies on small patient sample sizes. This often introduces site selection and statistical bias. Microcosting captures the granular detail of a specific case, but the labor required to track every minute of clinical time makes it difficult to apply across a national health system. Health economists face a constant trade-off: the significant expense of high-precision data versus the risk of making policy decisions based on misleading averages. Unallocated indirect costs and variations in patient severity drive these two methodologies to output different numbers for the exact same clinical service. This creates a challenge for comparing health systems globally. Studies use different combinations of perspectives, components, and valuation engines to analyze care. Benchmarking a top-down financial cost from one institution against a bottom-up economic cost from another creates a false comparison because the two methods use different mathematical inputs and definitions of value. This necessitates rigorous methodological transparency. Published cost data requires disclosure of every classification rule and allocation choice made before the final calculation. Standardizing a metric like a cost per bed day is mathematically impossible without first standardizing the rules that dictate how that number is built. Because in health economics, a given cost estimate is only as reliable as the exact methodology used to build it. In the end, the method is the metric.